Bioceramics in daily practice. Hello everyone, I'm Dr. Mina Mohab, endodontist from Egypt, and today I'm going to share my clinical experience with you about Wearroot ST and Wearroot PT. Wearroot ST is a pre-mixed bioceramic sealer that comes in a syringe form, while Wearroot PT is a pre-mixed bioceramic putty that comes in a capsule form. Composition for both are composed of calcium aluminosilicate compound as a bioactive component, zirconium oxide as a radio pacifier which does not cause any discoloration, and a thickening agent. Uses, of course, Wearroot ST, the bioceramic sealer, is used as a permanent root canal filling material in conjunction with gutta percha, while Wearroot PT, the bioceramic putty, is used in bulb capping, either direct or indirect bulb capping, bulbotomy, either partial or complete bulbotomy, regeneration, revascularization, lateral and focal perforation repair, as a retro filling material in apical surgery, external root resorption, and as a body plug in epixification procedures. Nowadays, there are so many studies that support the use of bioceramics. If anyone is interested, just search for the titles. What is hydraulics? Simply, hydraulics is the injection of the bioceramic sealer into the root canal space, then applying our master cone gutta percha to the full working length, which act as a piston that pushes the sealer into any susceptible microanatomy that may exist. Is it powerful enough to fill the whole root canal system to get a 3D obturation? Let's find out. Here is a case of upper second premolar, where the sealer filled two very tiny lateral canals. Here is a lateral canal filled related to upper canine. Here is a lateral canal related to the mesial root and apical delta related to the distal and lower second molar. Here is a lateral canal filled related to the palatal root of upper first molar. Here is a type C lower second molar where I wasn't able to achieve patency. I depended on the disinfection and activation. I injected Wearroot ST, then I placed multiple auxiliary tapered cones, and I seared off the gutta percha at the orifice level. And here is the two lateral exits were filled with the sealer. Here is a variety of upper central incisors. Upper central incisors has more than 40% incidence of accessory canals. The X-ray on the left is a lateral canal towards the buccal. The X-ray in the middle are two lateral canals where the sealer traveled a long distance to fill the longer one. The X-ray on the right are two accessory canals that divides from the main canal and return back again to the main, which is called a loop. This is 3D obturation. Wearroot ST will help you achieve the optimum apical seal in almost all types of cases, especially in the following case scenario. Long roots more than 25 millimeter, extremely curved roots, multi-planar curvature, S-shaped curvature, conservative shaping. Simply, neither the thermoplasticized gutta percha techniques nor the lateral compaction technique will fit here. Teeth with limited accessibility and limited mouth opening, compromised roots for strengthening large preapical lesions as it promotes healing. Here are the examples. Here is a case of multi-planar curvature combined by conservative shaping related to the mesial root of lower second molar. Here is a curved root combined by conservative shaping related to upper second molar. Here is a long and curved root related to upper first molar. The palatal canal here was 30 millimeter in length, while the distobuccal and the mesiobuccal was 28 millimeter in length. Here is a long and curved root related to upper canine. This canine was 31 millimeter in length. Again, long and curved root. Here is a variety of long and curved roots. Multi-planar curvature combined by conservative shaping related to upper second premolar. Multi-planar curvature combined by conservative shaping related to the mesial root of lower second molar. Here is a tough mesiolingual canal related to a lower second molar. Here is a case of conservative shaping related to upper second premolar with 3 canals. Here in retrieval cases, we sacrifice some dentin to remove the separated instrument. We compensate the lost dentin using bioceramics as it bonds to dentin and acts as a mono block. It strengthens the root. Here is another retrieval case. After we retrieve the separated instrument, we sacrificed the lost dentin using where root ST as it bonds to dentin and acts as a mono block. Here is a case of conservative shaping related to the mesio-pucker root of upper first molar with 3 canals. The X-ray on the right, there are 2 tiny lateral canals filled, one towards the mesial, one towards the buccal. The 1 year recall X-ray, the 2 tiny lateral canals are still filled with the sealer will root ST. In cases of limited accessibility and limited mouth opening, this is a lower wisdom. This is another tough, curved lower wisdom. Well-root PT, different clinical applications. Vital bulb therapy, indirect bulb capping, direct bulb capping, bulbotomy. Here are the examples. Direct bulb capping for the upper first molar. Direct bulb capping related to upper first molar. Direct bulb capping related to upper second premolar. Direct bulb capping related to upper second premolar. Again, direct bulb capping related to upper second premolar. Direct bulb capping related to upper second premolar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray related to upper first premolar. Again, deep carious lesion related to upper second premolar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray. Again, direct bulb capping for upper second premolar with 2 exposures, buccal and palatal. Direct bulb capping related to upper first molar. The 1 year recall X-ray shows a barrier was formed. Tooth is completely asymptomatic and responds normally to call. Here is a deep carious lesion related to upper first molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray. It's a predictable and a reproducible procedure. Here is a deep carious lesion related to lower first molar. Here is the immediate post direct bulb capping. The 3 year recall shows a barrier was formed. A barrier was formed. Tooth is completely asymptomatic, responds normally to cold with no any radiographic finding. Again, deep carious lesion related to upper first molar. Here is immediate post direct bulb capping. The 1 year recall X-ray shows a barrier was formed. The tooth is completely asymptomatic, responds normally to cold with no any radiographic finding. I think the difference is crystal clear. The barrier was formed. Again, direct bulb capping related to upper second premolar. Here is a deep carious lesion related to lower second premolar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray, all in one visit. Deep carious lesion related to lower first molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray. Again, another deep carious lesion related to lower first molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray. Again, deep carious lesion related to upper first molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray. Here is a direct pulp capping in the static zone. The X-ray on the left is the immediate post direct pulp capping. The X-ray on the right is 1 year recall, just slight narrowing in the bulb chamber, indicating a barrier was formed. The tooth is completely asymptomatic, responds normally to cold with no any radiographic finding. And here is a 1 year recall clinical image. There is no any discoloration in the central. This means that you are free to use this material in the static zone with no fear of discoloration, unlike MTA, which contains base oxide, which causes severe and tremendous discoloration. Direct bulb capping related to lower second molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray related to upper first premolar. Direct bulb capping related to upper first molar. Deep carious lesion related to lower first molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray. Deep carious lesion related to lower second molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray, all in one visit. Again, another deep carious lesion related to lower first molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray. And here is 1.5 year after. There is a slight narrowing in the bulb chamber, indicating a barrier was formed. Tooth is completely asymptomatic, responds normally to cold with no any radiographic finding. Again, exposure site, capped with putty, immediate post restoration, immediate post X-ray. Direct pulp capping in lower second deciduous molar, lower E. Direct pulp capping related to lower first molar. Here is a deep carious lesion related to upper first molar. Here is the exposure site, capped with putty, immediate post restoration, immediate post X-ray. Here is a case of upper second molar with two exposures were capped with putty, immediate post restoration, and immediate post X-ray, all in one visit. Now, here is a 50-year-old male came complaining of severe pain related to his lower second molar. Upon taking radiograph, I found a deep carious lesion related to the distal of the lower first molar. Now, what will be your treatment plan here? Simply, I did root canal treatment to the lower second molar as the bulb was highly inflamed and has to be removed, while I did direct bulb capping to the lower first molar as the bulb was healthy and could be kept alive. So I did direct bulb capping, but in such cases, a meticulous preoperative X-ray analysis should be taken care to avoid exposure, as if I went straight to address the carious site, I will go straight, then I will expose the whole distal bulb, hence I won't be able to cap this whole area. So I tilted my hand a little to avoid exposure of the projected distal bulb, only to address the carious site and to cap this pinpoint exposure with well root PT. Here is the 1 year recall. Both teeth are completely asymptomatic. Both are with no any radiographic finding. The first molar responds normally to cold. Here is a bulbotomy for upper second deciduous molar, upper E. Bulbotomy related to lower second deciduous molar, lower E. Bulbotomy related to lower second premolar. Indirect pulp capping related to upper first molar. Indirect pulp capping related to lower first molar. Indirect pulp capping related to lower second molar. Indirect pulp capping related to lower wisdom. Will root PT as a root canal filling material, bioobturation. Here's a treatment case of lower second molar where I filled the mesial root with will root ST in conjunction with gatapercha, while I filled the whole distal root using will root PT, the bioceramic putty. Here is a case I did 3 years ago. 2 years after, the patient came complaining of severe pain related to the tooth. After I took a radiograph, I found a radiolucency related to the distal root only. So I retreated the distal root only and filled with will root PT. And here is a tiny lateral canal was filled with the putty. Despite its consistency, it was able to penetrate the lateral canal. 3 days later, the patient reported as symptomatic. And here is the clinical research that supports the procedure: selective root retreatment, a novel approach. Here is a case of upper first molar where I filled the palatal root using will root PT, while I filled the other 3 canals using will root ST in conjunction with gatapercha. Here's another retreatment case of lower first molar where I filled both roots using will root PT. There is no fear of extrusion of the bioceramic material into the bone, as it's away from any vital structure. So caution should be taken care if near a vital structure, not to extrude either bioceramic or not near any vital structure like inferior alveolar nerve, mental nerve, or maxillary sinus. It's prohibited to extrude any material. Here's a trauma case related to upper central incisor where I filled the whole root canal system using will root PT. And here is the immediate post-obturation and restoration. Root canal treatment and vital bulb therapy in the same case. Can we do that? Can we do root canal treatment and vital bulb therapy in the same tooth? Let's find out. Here's a 9-year-old boy came complaining of severe pain related to his lower first molar. Upon taking radiograph, I found a deep carious lesion related to the tooth. Upon accessing the tooth, here is the exposure. Dark red profuse bleeding came out with a little amount of pus. Upon accessing the tooth, the clinical image on the left, the dark red profuse bleeding came out. The clinical image on the right after trials to control the bleeding. The clinical image on the left after more trials to control the bleeding. The mesial root was found, the mesial bulb was found unhealthy and has to be removed, while the distal bulb is healthy and could be kept alive. So I capped the distal bulb while I did root canal treatment to the mesial root. Here is a cone-fit X-ray for the mesial. Here, yes, follow me. Here is the immediate post-obturation for the mesial and capping for the distal. Here's a tiny lateral canal filled related to the mesial root using the sealer. The X-ray on the right is 1 month recall after stainless steel crown placement. The boy reported completely asymptomatic now. And here is the clinical research that supports the procedure: combination of non-surgical endodontic and vital bulb therapy for management of mature permanent mandibular molar teeth with symptomatic irreversible bulbitis and apical periodontitis. And here is the 14 months recall. There is a complete maturation of the distal root. This means that the distal bulb stayed alive till it continued the growth of the distal root. The X-ray on the left is 1 month recall. The X-ray on the right is 14 months recall. I think the difference is crystal clear. Extremely curved and long roots upper second molar. Here is a tough case of upper second molar with multiple curvatures. Here is a master apical file for the mesiobuccal one. Here is a confit X-ray, and here is the immediate post-obturation using well root ST in conjunction with gutta-percha. Gutta-percha will deliver the sealer to the full working length, as this root was 28 millimeter in length. Here is another view. Calcification management with the help of CBCT and Wilpex. Here is a case of upper first molar. After I accessed the tooth, I found only the mesiobuccal and the palatal canals. I didn't find the distobuccal canal. I took multiple shifted X-rays, hoping to find any connection or to find the distobuccal root outline or the distobuccal pulp space, but I couldn't detect this. I suspected fusion between the distobuccal root and the palatal root, so I injected Wilpex, which is a calcium hydroxide with iodoform, highly radiopaque, sharp yellow in color, hoping to find any connection between both roots, but I didn't find the connection. I got only a lateral canal related to the lateral radiolucency in the palatal root. So I decided to do root canal filling to the mesiobuccal and the palatal using Go root ST in conjunction with gutta-percha. Then I placed a drop of Wilpex in the search area of the distobuccal canal. And then I take multiple X-rays hoping to find the distobuccal canal orifice, but I didn't find it. And here is a clinical image, the mesiobuccal and palatal obturation and the distobuccal where we put the Wilpex drop. We used this drop as a reference. Then after I sent the patient to take a CBCT, I used this drop as a reference. The CBCT told me that I need to go 1 millimeter beyond the drop of Wilpex near the distal marginal ridge. So after ultrasonic troughing, I was able to detect the distobuccal canal. So I used the Wilpex drop as a reference here. If I continued in this direction, I would have made a perforation. It's inevitable. But it helped me as a reference. And here is the immediate post-obturation using Go root ST in conjunction with gutta-percha. Separated file retrieval. Here is a referred case from a colleague for separated file management in lower second molar. After I retrieved the separated instrument, I compensated the lost dentin using Bioceramics. Here is the immediate post-obturation using Go root ST in conjunction with gutta-percha. The 1 year recall shows complete healing of the radiolucency. The radiolucency completely disappeared. Another retrieval case in lower first molar after we retrieved the separated instrument using tube technique. We compensated the lost dentin using Go root ST, which was able to fill the furcal canal related to the furcal radiolucency. Here's the 1 month recall. The patient is completely asymptomatic after crown placement. There's a slight reduction in radiolucency size. Again, another retrieval case of a long, large separated instrument in the mesiobuccal root in upper second molar. After I retrieved the separated instrument, I compensated the lost dentin using Go root ST in conjunction with gutta-percha. Here is another view. Pulp stone and multiple radiolucency management with 3 and 6 months recall shows healing and 1 year recall for direct pulp capping. If you remember this case, we did direct pulp capping for the lower second premolar. Unfortunately, there were a hole on the crown. Leaking food led to caries, hence bulb necrosis and apical periodontitis. After I removed the crown, I found a bulb stone. And here is a clinical image of the bulb stone. It was blocking the canal entrances. With the help of ultrasonic, we break this stone into pieces, revealing the canal entrances. And here is a confit X-ray, and here is immediate post-obturation using Go root ST in conjunction with gutta-percha. There are two tiny lateral canals are filled, one in the medial, one in the distal, related to the lateral and the focal radiolucency. And here is the 3 months recall. There is a significant reduction in radiolucency size. Significant reduction in radiolucency size. The X-ray on the left is the immediate post. The X-ray on the right is 3 months recall. There is significant healing. The 6 months recall, it's about almost healed. And here is a 1 year recall for the lower second premolar, the X-ray on the right. The tooth is completely asymptomatic, responds normally to cold with no any radiographic finding. Calcification management. Here is a referred case from a colleague for the inability to find the mesiobuccal canal in lower second molar. After I removed the calcific tissue, which is white in color, I was able to detect the test to the mesiobuccal canal orifice using ultrasonics. And here is a confit X-ray, and here is immediate post-obturation using root ST in conjunction with gutta-percha. And here is a tiny lateral canal filled in the apical part of the medial root. The lateral canal was related to the mesiobuccal canal. Here is a tough case of complete calcification of upper first molar. At first, I was able to detect the mesiobuccal and the palatal canals, and here is a confit X-ray. After a while, with ultrasonic troughing, I was able to detect the distobuccal canal orifice. And here is a confit X-ray for all 3 canals. The distobuccal canal orifice was located in a bizarre location on the distal marginal ridge. Unfortunately, during search, I did a tiny perforation, which was repaired later using root PT. And here is immediate post-obturation using root ST in conjunction with gutta-percha. And here is an apical delta related to the mesial root. Hydraulics power. Bioceramics are a real savior and a game changer material. How? How to get away with a separated file. Here, a 16-year-old girl came complaining of severe pain related to a tooth that was previously root canal treated. After I took a radiograph, I found a long, large separated instrument related to one of the mesial canals and the mesial root. After I took a shifted X-ray, I found that both the mesiobuccal and the mesiolingual canals are joining in one apical foramen. At first, I tried to bypass the long, large separated instrument, but unfortunately, I wasn't able, and I broke 3 more hand files. I tried to remove the long, large separated instrument, but I couldn't. I just removed my hand files that I broke. So I decided to bypass the separated instrument from the other canal, as both canals are joining in one apical foramen. So if you seal the foramen, there is no problem and the prognosis is high. And here is the immediate post-obturation using root ST in conjunction with gutta-percha. The apical seal is achieved. And here is 1 month recall. The girl reported completely asymptomatic, and there is a slight reduction in radiolucency size. By the way, this case has 2 years now, asymptomatic. Here's another referred case from a colleague for separated file management in the second mesiobuccal canal and upper first molar. After I retrieved the separated file, unfortunately, there was a 90-degree curve in the apical part of the second mesiobuccal canal. So unfortunately, a 1505 rotary file was separated in the apical part. I wasn't able to bypass this tiny instrument. So I injected root ST. Then I placed the gutta-percha cone, which pushed the sealer beyond the separated file. So the apical seal is achieved. Here's another tough upper second molar with multiple curvatures and very narrow canals. I shaped the 3 main canals first, but unfortunately, during shaping of the second mesiobuccal canal, a 1503 rotary file was separated and I couldn't bypass. It was very, very tiny canal. So I injected root ST, then I put a gutta-percha cone which pushed the sealer beyond the separated instrument. It's quite obvious in the negative image. If you have a closer look, you will find the sealer and gutta percha beyond the sealer, beyond the separated file, and joining the first mesiobuccal or the mesiobuccal one. Perforation repair. Here is a referred case from a colleague for the inability to find the distobuccal canal and for perforation repair. The clinical image on the left is the mesiobuccal canal orifice. The red dot is the perforation site. The clinical image on the right is after location of the distobuccal canal after ultrasonic troughing and removing the calcific tissue. Here is the immediate post-obturation and perforation repair using Will Root ST, the sealer. It's a tiny perforation, can be sealed with the sealer. There is no problem in this. Here is another retreatment case of lower second molar. After I removed the gutta percha, I found a tiny perforation in the furcation area. After locating the mesial canal, and here is a cone-fit X-ray for the mesial and the distal. Down backing for the distal for the bioceramic heat lovers. Here is immediate post-obturation and perforation repair using Will Root ST. Here a case I did 3 years ago. The X-ray on the left is the immediate post-perforation repair using Will Root PT. The X-ray on the right is 3 years after. Will Root PT still the same way as it is. The putty did not wash out by time. Despite this area, it's highly susceptible to wash out due to the proximity to the oral cavity environment. Any bioceramic material would suffer such circumstances, but Will Root PT did a very, very good job. It lasts more than 3 years the same way as it is. Here's another calcification case. During surgery for the canals, I did tiny perforations, which was sealed using Will Root PT. Then I did obturation to both roots using Will Root ST in conjunction with gutta percha. Perforation repair during search for the middle mesial canal in lower first molar. Here is a referred case from a colleague for the inability to find the mesiobuccal canal and for perforation repair. Here is a file in the perforation site, and here is the perforation site clinically, the granulation tissue inside. After removal of the granulation tissue, here is the perforation site periphery. Here is the file in the mesiobuccal canal orifice. Here is a cone-fit X-ray after obturation using Will Root ST in conjunction with gutta percha. After perforation repair using the butty. And here is the immediate post-obturation and perforation repair using post-ST and PT. Furcal canal. What is a furcal canal? Let's find out. Here is a case of lower second molar. After I accessed the tooth, I found 3 canals, 2 in the mesial, 1 in the distal. During the working lens using electronic apex lutator, the mesiolingual canal keeps giving me that I'm out of the root. Apex locator keeps giving me that I'm out of the root. So I decided to take multiple radiographs to see what is happening. Here is the initial file for the mesiobuccal canal. There is no problem in this one. Here is the file in the mesiolingual canal that the apex locator keeps giving me that I'm out of the root. It looks inside of the root, but I'm not so sure. So I decided to take another wider shift. Here I am out of the root. Actually, it was detected as a furcal canal. What is a furcal canal? Furcal canal, it's a very, very short canal, which is a canal that starts and ends in the furcation area, like letter A in the diagram on the right. It's a very, very short canal. We don't use gutta percha here. Here is a clinical image for the axis. It looks like a C shape or an isthmus that connects the canals together. This is the mesial, and here is the distal. After dryness, the furcation area looks bizarre. Here is cone fate X-ray for the mesial and the distal. Here is immediate post-obturation using well root ST in conjunction with gutta-percha for the mesial and the distal. I filled the furcal canal using well root PT, while I filled the isthmus area using well root ST. It's an empty space and has to be filled. Here is a negative image. Well root ST filled the isthmus area, the area that connects the canals. It shouldn't be left empty, it should be filled. External root resorption. Here is a case of lower first molar with massive external root resorption related to the distal root with massive radiolucency related to it. Here is the immediate post repair using well root PT. The 6 months recall shows a significant reduction in radiolucency size, and the patient is completely asymptomatic. The difference is crystal clear. Here is a case for a female colleague that came complaining of severe pain and swelling related to her lower first molar. Upon taking radiograph, I found a massive external root resorption related to the distal root with massive radiolucency related to both roots. She was keen to give her tooth another try as she was a dentist, so here after we removed gutta-percha from the mesial, and here is a large H file in the resorptive defect. After removal of gutta-percha, unfortunately a part of the gutta-percha was extruded through the resorptive defect. And here is a cone fit X-ray for the mesial. I decided to obturate the mesial root first, as the distal orifice was oozing blood and exudate. So I blocked the distal orifice using Teflon. Then I obturated the mesial root using well root ST in conjunction with gutta-percha. Here, after I fitted the cone for the distal, I decided to use the sealer as well to see how the material will act in such tough circumstances. Here is the immediate post-obturation using well root ST. The sealer sealed the resorptive defect. The clinical image on the left is during gutta-percha removal, where pus coming out after obturation of the mesial and the distal. And here is another clinical case, shows how external root resorption may look alike. It's a radix root of a lower first molar. The 4 months recall shows significant healing and significant reduction in radiolucency size. The patient is completely asymptomatic now. The sealer did a very, very good job sealing the resorptive defect without being washed out, as the bioceramic sealer needs at least 2.5 hours to set. This area is filled with blood and exudate. It could be easily washed out, but thanks to the high amount of calcium silicate present in the composition, it's a very solid, stable matrix. The 8 months recall shows complete healing. And here is another view. And here is a clinical study that was published comparing different bioceramic sealers worldwide. They found that well root ST was found to be the most effective for human for attachment of human periodontal ligament stem cell on the set surface. So the BDL will continue to form again on the set material. It's a tissue friendly and highly biocompatible. And here is day 0, 4 months and 8 months recall. It's almost completely healed in a short period of time for this massive size radiolucency. Intentional replantation and crack management. Here is a case I did 10 years ago in 2013. I did direct composite restoration in a lower first molar. Unfortunately, 5 years after, in 2017, apical periodontitis started to appear under the mesial root. In 2019, we did root canal treatment. In 2019, the tooth is almost healed. Unfortunately, in 2021, a horizontal crack pattern started to appear, and here is a crack line stained with methylene blue dye. I decided to retrieve the tooth and fill the whole root canal system of both roots using Root PT, the bioceramic putty. Unfortunately, the patient was still having symptoms, so I extracted the tooth and cutted the apical part of both roots. And here is the immediate post-intentional replantation, immediate post-clinical image. The 3 months recall after intentional replantation shows healing, and the patient is completely asymptomatic now. By the way, this case has 2 years now functioning. It wasn't extracted yet. Here's another case of intentional replantation referred by a colleague for the inability to remove or bypass a separated instrument in a dilacerated mesiolingual root of a lower second molar. So I disinfected the canals very well, injected Root ST, extracted the tooth, cutted the apical part of both roots, then put it back again into the socket. Lateral canal scouting. Here's a case of lower first molar. During scouting the distal root, I was able to detect a lateral canal. Unfortunately, the hand file was separated inside the lateral canal. Here is a separated file in the lateral canal, but after injection of Root ST, the bioceramic sealer, and adding the master cones, the sealer was pushed beyond the separated file. So the sealer fixes the problem. Here is a negative image. Here is another case of lower first molar. Here is after one scouting trial. In the second scouting trial, I was able to detect a lateral exit for the distal root. And here is a cone-fit X-ray for both the mesial and the distal. And here is the immediate post-obturation using Root ST in conjunction with gutta-percha. The tiny lateral canal was filled with the sealer. Deep split management for non-microscopic clinicians. Here's a case of lower first premolar. In the preoperative X-ray, it's quite obvious that it has one main canal and 2 tiny splits. Here, after scouting trials, clinical image. After more scouting, shaping file in one of the splits. Here, 2 files in the 2 splits. So the 2 splits were detected. Here is a clinical image. Here is a 4004 rotary file in the main canal. Now, how I will apply the gutta-percha cone inside the splits. So I tried to make gutta-percha harder, more stiff. So I placed on an ice cube and sprayed with endo ice to make it more hard, more stiff, to introduce inside the canals. But unfortunately, I wasn't able to introduce the gutta-percha cones in the splits, as I wasn't seeing the splits. So I decided to depend on the hydraulics power. So I decided first to block the main canal. I chose the largest gutta-percha cone that gives me the tightest tug back. Then I down back till the split level. So I blocked the main canal so the sealer cannot escape from the main canal. Then I injected the sealer and placed the rest of the cone. Here the sealer was pushed with the gutta-percha cone inside the 2 tiny splits, and here is a tiny lateral canal in the mesial started to appear. Here is after adding more sealer and more auxiliaries. Here is a clinical image after adding tapered auxiliaries. It gives more pushing in wide canals to push the sealer harder, so you get the advantage of hydraulics of the bioceramic sealer. After sealing off the gutta-percha at the orifice level, the 2 tiny splits were filled and puffed with the sealer, and the tiny lateral canal was completely filled. Again, here is another lower second premolar with multiple splits. After scouting trials, 3 splits were detected. Here is a master apical file for each split. Unfortunately, the rotary file was separated in one of the splits. I wasn't able to fully bypass. It's a tough bypass, by the way. So I decided to inject whole root ST, then using the gutta-percha cone, which pushed the sealer beyond the separated instrument. And here is the immediate post-obturation using whole root ST for both the first and second premolar. Here's another lower first premolar with multiple splits, which was a part of a bridge. After scouting trials, 2 splits, 3 splits, 4 splits were detected. And here is the master apical file for each split. And here is a cone fit X-ray for the splits. And here is the immediate post-obturation using well root ST in conjunction with gutta-percha. Here is a quote from my mentor, Dr. Alan Nasih. If you're always worried about failure, you will never reach out for success. Thank you, and I hope you enjoyed the presentation. Thank you. Thank you so much. Thank you. If any questions, I'm more than welcome. For further information, you can contact me on this